I'm Kathy Hardacre. I'm a registered nurse in the burn trauma ICU, and today I'm going to be talking about end-tidal CO2 monitoring, hypothermia, some tips for burn care, talk about our vitamin C, and mold in the unit. So first we'll start with end-tidal CO2 monitoring. Our background is that patients' harm occurrences have occurred related to inconsistent monitoring during dressing changes and with administration of opioid and benzodiazepine medications. The potential harm is an unrecognized opioid-related sedation, respiratory depression, anoxic brain injuries. So what we've done is identified that the inconsistent monitoring in unintubated patients, we need to use our capnography monitoring. Capnography parameters are with your ABG levels of PaCO2 of 35 to 45, or the nasal cannula. ETCO2 is one way to read it as well. It's 35 to 45 millimeters per mercury for healthy pulmonary function. Why is this so important? Capnography diagnoses the presence or absence of patient inspiration quality. Who are we using this on? All non-intubated burn patients. Our equipment is our Philips IntelliView monitor with end-tidal CO2 monitoring capabilities. And you plug it in to this side, and if you don't have this, you need to be finding one in another room. It slides down. It is a different nasal cannula. This part of it is downward into the patient's nares, and it will show up on your monitor as end-tidal CO2. I want to turn this on so you can see how to add your end-tidal CO2 monitoring if you don't have it. You go down to the bar, you're going to select end-tidal, activate, set up, scroll down, select on. Go to your main screen and you can see that it is now activated on your screen. Next we are going to talk about the perioperative hypothermia. We need to consider that the operating room is set at 67 degrees Fahrenheit. We have asked the operating room to warm the operating room to 80 degrees. It takes about an hour for that to warm up to that degree. The background is, as I said, 67 degrees Fahrenheit. We have seen poor patient thermal regulation induced by hypermetabolism in burn patients. Anesthesia further exacerbates hypermetabolism, intensifying heat loss. Prolonged exposed skin causes heat loss. Trauma injury plus poor heat production with poor temperature of 30 to 32 degrees Celsius is associated with nearly 100% mortality. In our assessment, we're going to determine who is high risk. All of our burn patients are potential prolonged OR cases. All burn patients with poor thermoregulation, hypo or hyperthermia, poorly managed poor temperature prior to admission, and OR. Who's at risk? All burn patients. Anybody with TBSA greater than 20%, partial and full thickness burns are at risk. OR time greater than 3 hours. Recommendations. We have mild, moderate, and severe risk. Mild is none. Moderate risk, increasing the OR temperature to 76 or 80 degrees, according to the TBSA, or elapsed time and patient response. We warm our IV fluids for anything greater than 500 cc's as a standard, and then we have our Ranger warming device for all of our other fluids. Our TBSA will be 10% or more in the moderate risk category. Severe risk, pre-warming of patients to 42 degrees, can be done by esophageal or vascular warming devices placed by a physician and removed by a physician. The equipment the nurse has available is heat lamps, Ranger IV warming, the esophageal warming, intravascular warming. Forced air warming devices include the Therapulse bed and the Bear Hugger blanket. Patient room thermostat should be increased to 80 degrees. Cooling and heating blanket machine set on warm. Our burn care tips. Burn care tips, please remember administration of scheduled Lovenox prior to burn surgical procedures unless orders state to hold. All male patients will be shaved daily. Cover all wound surfaces when applying Methylex AG with no gaps. Secure with Curlex and ACE bandages. You will also see them stapled. Obtain lemon spore for all burn patients not intubated prior to admission of benzodiazepines. The lemon spore was covered earlier. Appropriate reversal agents for narcotics. Be sure you have your Narcan or your benzodiazepines and Romazicon for benzos. And post-surgical takedown dressings may have Telfa dressings in place instead of the Methylex, and that's to reduce the initial painful dressing change to the donor site. Please chart all burn dressings in the appropriate area for assessment and grafts. Cocoa butter application must be removed with dial soap and water daily, and then reapplied with every dressing change if warranted. We now have 454-gram bacitracin jars. Please request from pharmacy if they're not available in your Omnicell. Ordering of blood cultures will be held until post-op surgical day 2. Zeroform Baci will soon replace the application of silver sulfadiazine for partial and full thickness burns. To the topic of vitamin C, Dr. Cheatham and Dr. Howard Smith have done research which shows that using a vitamin C drip in our burn patients has side effects of renal impairment. So for the time being, we are not using vitamin C drips. There is a possibility of a PA catheter being used without the use of vitamin C drip, and that is dependent on physician recommendation, preference. The last thing I want to talk about is mold. We've seen mold in our burn population, and some of the things that you're going to be seeing is that we have eliminated our isogel mattresses, and we have replaced all of our mattresses with the AccuMax, and all of our equipment, including our bear huggers, our level 1s, our Rangers, any equipment that we will be using at the bedside is now going to be streamlined and taken to equipment management for thorough cleaning. That system is in progress, and more to come on that.